Good morning. My name is Don Rule. I'm the founder of a company called Translational Software. And our goal in life is to take the last mile to translational medicine by making the things that have been learned in the bench out to the bedside. The idea for the company came while I was at Microsoft. I realized that the ability to digitize biology gave a lot of opportunity to someone who was a software person to make it useful for healthcare. So we have been around since 2013 we launched. Our first customers were largely laboratories. And we have about 80 laboratories working with us now, but we're moving into actual healthcare organizations. So we're currently working with Innova Hospital in the Washington, D.C. area. They are sequencing every baby born in their Fairfax, Virginia hospital, and working with a group, an IDN called Sanford in South Dakota, where they are growing their ability to use pharmacogenetics in their daily practice. So our vision is that we're going to have a tremendous amount of genetic information available. It should be available to everyone, everywhere, through their health records. And we started with pharmacogenetics for a couple of reasons. One is that the evidence for it is very good. The FDA required testing for the metabolism pathways for drugs at the time they were approved. So there's excellent information about what the difference is between genotypes and what result it has in people's, the effectiveness of medications for people. The other reason is that an awful lot of people take medications. So when we look in our database, people 80 to 90 years old are on average taking 9 medications. And it's pretty common that they're taking some of those medications just to counteract the side effects of some other medications that are on their list. We hear pretty consistently that the people in long-term care feel that being able to understand the underlying issues underneath adverse drug reactions helps them to manage patients, eliminate falls, and they think eliminate mental fog. So it's also true that a relatively small set of genes affects an awful lot of drugs. So between 15 and 20 genes, if you test them, you can understand pretty well between 200 and 300 drugs what the effects are. The other reason for pharmacogenetics is I happen to meet up with Huda Hachad, who is my chief science officer. She is a PharmD that spent 10 years at University of Washington, first in drug-drug interactions and then in drug-gene. And she participates in the committees that actually create the guidelines. So today we're largely working with labs. We've done about 800,000 interpretations and provided reports for them. But where we need to go is from this reactive mode, so sort of from diagnostic to screening. So right now, if you're going to be prescribed Plavix, you'll get a test. That's sort of backwards. If you're going into the emergency room, it can be kind of nice to know how you're going to, how warfarin is going to affect you. If you look at the warfarin label, you can be prescribed anywhere from 0.5 to 7 milligrams per day, and 60% of that variation is explained by genetics. It'd be kind of nice to know preemptively how that affects you. Also today, we're largely static. What we provide, for the most part, is a PDF that goes into your medical record. It would be nice to be able to do that dynamically so that as your medication list changes, you can understand what the implications are. Today, it's largely just in the chart of the person who ordered the test. It'd be nice to know that if you went from your general practitioner to your dentist or your cardiologist, that they could understand the implications that they prescribe, and they could understand a priori. So instead of maybe finding out downstream from the pharmacist or from your general practitioner that something someone else prescribed was wrong, you could know it a priori. And today, virtually all these systems are standalone. Sometimes you can get the PDF in a medical record somewhere, but it would be great to have a much, much tighter level of integration would make it much easier for a doctor to use. So what does that integration mean? First, it's integral to a care plan. So if you're going into a catheterization lab, okay, get a pharmacogenetic test that you know how clopidogrel and warfarin are going to work for you. Second, at the time you're prescribing amitriptyline, it would be great to know that a test is relevant for that, and it might be very important. Third, at the time you're being told that amitriptyline is potentially problematic, it'd be nice to know what test to get. And in fact, to be able to look at all your medications and say, what's the appropriate test given this span of medications that I either have or might have in the future. It'd also be nice to be able to look across the population and say, who is it that should get a test? Clearly, many people are taking medications that aren't affected by variations in the genome, but roughly 30 to 50%, depending on the age, anywhere from 20 to 50% are, and in some cases 70% in the elderly population. It'd be nice to know at the time you receive the report that to get an alert of some sort that you should pay attention to it, so management by exception. It'd be nice to know for a physician, if there is a problem with one of the medications, to be able to quickly look for alternatives that don't violate issues with either drug-gene interactions or drug-drug interactions, and that's what I'll demonstrate in a minute. It'd be nice to know that you've maintained the list of your genetics in some way so that any decision being made in the future can be made on the basis of that genetic result. Today, I worked in the HL7V2 clinical genomics working group since 2012 or so. We have provided the capability to get the discrete genetic test results in the HL7 record, and sometimes that goes back to the EMR. Frankly, very, very few end systems are capable of understanding that genetics. And in order to do clinical decision support, we're layering on this FHIR layer that allows you to more interactively requery that data. Something that's really important, though, as we look at this, Clem McDonald at NIH and Molly Ullman are working on the standards for V2, now called V2 Lite, which is not quite so light, that help to integrate genetics into it. What is incredibly important is that we make sure, as these two standards evolve sort of in parallel, that the way that we capture the genetics is semantically equivalent in both places. So that if I take and put a test result into an EMR with this V2 system, that we know that from a clinical decision support, you'll be able to read it. So here's what the stack looks like now. The core at the bottom is a number of different types of interpretation: pharmacogenetics, drug-drug interactions, nutrigenomics, cystic fibrosis, oncology, and we're adding to that all the time. We also have file processing, reporting, patient data at the core. On top of that, we're layering an API that allows you to evaluate that information. It's basic CRUD functions to update the patient data, but more importantly, the ability to query it and understand on the basis of a new set of genes, or the ability to order a test from one of our labs. And the sort of at the top of the stack is the ability to take a user interface widget and put it into the health information platform that you have. So, if I can find that. There we go. This is a little demo of where we are with the first of our widgets. This is our own patient portal, but you can imagine this being any system that you might be able to launch it from. So this is sort of your old-fashioned, here's the PDF. And in this PDF, we can see what are the implications of the genetic test result for the medications that this patient is taking. And then what are the other risk factors that affect how you prescribe medications? And then for those medications that are problematic, what are the alternatives that are viable? Now, this list gets to be fairly complicated, particularly when you add drug-drug interactions, because you're thinking along two different dimensions. And very few people in the world have the capability to keep all that straight in their minds. So what we've created is something we call, working title, is Medsreview. And the idea of Medsreview is to be able to see both gene-drug and drug-drug interactions in the same context. So I can look at this issue with 2C19 and I can find an alternative to it and substitute that drug. I've gotten rid of one problem. Now I have another drug that's very problematic. And I can look at either side of the interaction and decide which to swap out. I'll substitute this. And you can see a problem that might take you a long time if you're separately looking at charts of drug-drug and drug-gene is very, very easy to navigate. And we've kept track of your changes. So if you had to back one of them out, sometimes you go down a rabbit hole and have to back out and look for a different path. When you have extremely complicated long lists, that happens sometimes. And then you can see we keep track of the changes that you've made. And the intent in the future is to be able to push that into your medical record or look at what changes you have made on the basis of the genetic test. And if you're aware, the biggest problem we all have in precision medicine is convincing payers that it's worth paying for because somebody actually took action and ultimately that the outcomes have been better. This piece of data, we think, is going to give us the ability to prove to payers that physicians are taking action on their genetic test results. I'll switch back here. So this is a list of the endpoints that we've used. If you're interested, we can go into more detail in this, but essentially we're using basic capabilities to look at patient data. We use detected issues, which is essentially the ability to say, is there a drug-drug or drug-gene issue within this? And we have a couple of extensions to be able to do in a stateless way. So we'd like to be able to say, our system over time will deal with just de-identified data. So in a stateless manner, you can send us the drug list and the genetic list or an accession number into a lab. And even if we don't know who that patient is, we can give you the results of the screen. So the technology is moving very quickly. Genetic testing is much cheaper than it has been in the past, and it's getting cheaper all the time. Pharmacogenetics, we have pretty good evidence, can help in a variety of ways to lower the cost of managing patients, particularly elderly, particularly people who have chronic illnesses. The awareness and adoption of precision medicine is growing very quickly, but one of the largest impediments is the ability to use it easily. If a physician is seeing 30 to 40 patients per day, if you add a minute onto that for reviewing the genetic test result, that is extremely problematic. So it's tricky to get this into the healthcare organization. We're working sort of up the stack with our clinical organizations and having very good luck, very good success. I'm very interested in talking to you about some of the areas where we might collaborate. Thank you very much.